Hi, this is Jeremy. I'm the SRNA that was taking care of Mr. Red during his colonoscopy today. Trying to give a report to the nurse who's going to be taking him. Can I ask your name? Alright, so as far as past medical history, I have Mr. Red. He's an 83-year-old male. He has no known allergies. He has a history of metastatic esophageal cancer, diagnosed about a year ago. He's been treated with chemo and radiation since then. He hadn't been improving with those treatments. He was getting recurring esophageal and gastric malignancies and decided to go on hospice care about 2.5 weeks ago. As far as underlying diagnosis and procedure we did today, Mr. Red was complaining of abdominal pain and having no bowel movement in over 2 weeks. So he came to the hospital, to the ER today. They did a CT of his abdomen, and it showed a small bowel obstruction and a mass in his descending colon. GI was consulted, and they planned to do a therapeutic colonoscopy with possible colonic stent placement to relieve some of those symptoms that Mr. Red was having. Prior to the case, he was cachexic, weak, mainly bedbound, and used a wheelchair sparingly. As far as the technique we were going to use, we plan to use moderate sedation with a propofol infusion, about 25 to 50 micrograms per kilogram per minute. We did not plan on intubating Mr. Red. We're going to use an oxy mask, about 6 liters. His vital signs prior to the case were good. We're going to use end-tidal CO2 monitors as well. And intraoperative events. So the doctor had a real hard time advancing the probe because of the tumor in his descending colon. It took him about an hour just to get to the area of stricture where he was going to even attempt to place the stent. Upon attempting to place the stent, Mr. Red's vital signs increased, or changed rapidly, I should say. His heart rate went to 122, blood pressure went up to 174/19, respiratory rate was 30, and his pulse ox was 98 to 100 on those 6 liters oxy mask, and his end-tidal CO2 was still good. We noticed some abdominal distension at that time, and the doctors had suspected a bowel perforation. Also at that time, he had a decreased SpO2 pleth waveform, and we noticed some venous congestion, JVD, erythema, and purple discoloration to the right side of his neck, and then also we noticed some subcutaneous air on his right neck and face. That time the case was immediately aborted and a rapid response was called. The patient was emergently intubated. After the intubation, a doctor did needle decompression on the patient's abdomen. You could hear air release from that, but he was still having high peak inspiratory pressures, over 40 centimeters of water, and his tidal volumes were low at 180 to 200. And at this time, we noticed that we had absent right lung breath sounds, and he was becoming hypotensive and more tachycardic. So a tension pneumothorax was suspected. The doctor did a right side needle decompression for that. Chest x-ray was done and showed bilateral tension pneumothoraxes, and right and left chest tubes were placed by the doctor after those findings. Chest tubes were set to 40 centimeters of water suction, and immediately after the 2 chest tubes were placed, the patient's vital signs normalized. His subcutaneous air got a little better, and the venous congestion on his face, or on his neck rather, was pretty much gone immediately. His vitals had normalized, like I said. The most recent ones we have are heart rate 114, sinus tach, blood pressure is 125/82. His pulse ox is 98, and now he is on the vent on mode PRVC. FiO2 is 40%. His tidal volume is 450, PEPA 5, rate of 16. As far as lines, Mr. Red has 2 PIVs, peripheral IVs, 18 gauges each. They're one right forearm, one left forearm. He's got those right and left pleural chest tubes, both set to 40 centimeters suction. He's got a 7.0 ET tube at 23 at the teeth, and he's got a J tube that was present prior to the case. As far as therapeutic interventions, he's not receiving any pain meds now, not complaining of pain at the moment. He is lightly sedated with propofol drip, 25 to 50 mics per kilogram per minute. He has been purposeful still with that since the chest tube placements. and everything's calmed down a bit. He squeezed my hands to command and wiggled his toes to command. Antibiotics, I've given him 1 gram of Ansef at the end of the case, and fluids, he got 500 cc normal saline bolus. As far as ins and outs, just that 500 in and 0 out. Intubation, he was a difficult intubation because of the subcutaneous air emphysema that was present in the oral cavity. It is a little better now. Extubation likelihood, I think he's likely to be extubated. I do want a pulmonologist to give recommendations on whether or not to extubate because of that subcutaneous air and the chest tubes being present now. He was comfort care, hospice prior, so I'm kind of expecting us to wean his sedation and see what the family and him want to do as far as goals. Need for drips, he's on no vasopressors now, just the propofol infusion at 25 mics per kg per minute. And then treatment planning suggestions: move to the ICU, decrease sedation, make sure he's mentally, appropriate, extubate if okayed by the pulmonologist, and then have a family discussion, patient discussion about goals of care and treatment plan going forward. We'll also likely need to give him something for pain because we have a suspected valve perforation, and I do recommend that we consult pulmonology, palliative care, spiritual care, and maybe inpatient hospice and pain management if possible. As far as recent labs, Mr. Red doesn't have any recent labs. Per the MD orders, all the labs prior to the case were stable. That's pretty much all I got for you. Do you have any questions for me? Alright, well, I was told family would be in the waiting room. The main contact point for us has been Mr. Red's son, Mr. Blue. We will be up there with Mr. Red in about 5 minutes. Thanks. We'll see y'all soon.